It is my great pleasure to introduce to you Dr. Howard Abrams. Dr. Abrams is an innovator, but more importantly, he's a person who cares about other people and about building community. Dr. Abrams knows that it is through community that we become fully human. I suspect he learned this through his studies in anthropology and ethnomusicology and by living with a nomadic tribe in northern Kenya. With a degree in engineering and an MD with a specialty in internal medicine, Dr. Abrams has worked in Northern Ontario, Africa, and Asia to help develop community-based services and research capacity. I knew we had to have him come speak to us when I read what he said in an article in the Walrus. I saw too many seniors abandoned to understaffed hospitals with nowhere else to go but government-run nursing homes to believe that there couldn't be a better way. We couldn't agree more. And this is why we're so honored to have Dr. Abrams share his wisdom with us today. Over to you, Dr. Abrams.
Thank you, Trish. Can you hear me okay?
Yes.
Okay. Can you put up the first slide, please?
Sure.
Great, perfect. So thanks for that very kind introduction, Trish. I'm honored to be invited to speak to you folks. I went to the Seniors Action website and very impressive. I mean, it's there's such a long history there and there's so much that we have in common. And it saves me a lot of time because I don't have to explain to you what the urgency of all this is. I'm sure you're very familiar with a lot of the things I'm going to talk about. So I'll just explain about myself a little bit. And if you do have questions, as Trish said, you could enter them in the chat, or after I finish, perhaps you can use the raise hand function, and we can take some comments as well. So as Trish said, I'm a doctor at the University Health Network. I describe myself as semi-retired. I keep trying to retire, but they keep running short of doctors. So I keep saying, okay, well, call me in if you need me. And they seem to need me every once in a while. But I'm also the director of OpenLab, which is a innovation and design group based out of UHN, but pretty independent of the hospital. And I can explain why in a little bit. So in terms of our Norc Innovation Center, or NIC, I'm the medical director. The leads are actually Jen Recknagel, who's the creative and innovation lead, and Melissa Chang, who's the operations lead. So let's go to the next slide. So these are the items I'm going to try to cover during the next half hour, 40 minutes, and then we'll have lots of time for discussion. So I'll just describe briefly what OpenLab is and what is a Norc. You're probably familiar with this, but there's a little bit of clarification that seems to be confusing some people in the community. I'll describe what the opportunity is that Norc represents, and then talk specifically about our Norc Innovation Program, or Norc Innovation Center. Final screen will show resources that we have available, so 3 different websites. All right, next slide, please. So what is OpenLab? So we're kind of a funny organization. We're a service design and innovation shop looking for creative solutions at the intersection of health and society, which really doesn't explain very much. We're not really a research group, although we do research. We're not really an implementation arm of the hospital, although we do implement programs. We're kind of a funny hybrid. We like to think of ourselves as a let's do it group, let's get it done, rather than let's publish about it or talk about it. Next slide, please. So our philosophy is very much what we call transdisciplinary and transmedia. We don't particularly define ourselves by our degrees or what our how people label us, but we do engage a lot of different types of people. There's a very small group of permanent staff, but we each have a very large network behind us. So we work with designers, clinicians, engineers, family circles, videographers, app designers, researchers, policymakers, etc., and just about any other kind of person you can imagine. We use what's called a design thinking approach, which when we started back in 2007 was not very well understood, but it has now become kind of a mainstay. It could be called user experience, user-centered. It's really thinking about who are we serving and what are their expressed and unexpressed needs? How can we understand those? And then how can we work together to try to meet them? And we also have this notion of open source innovation. So contrary to the usual academic or commercial innovation where you try to hold your ideas very closely because you want to own them, we believe that if we're doing something that could be a benefit, then we should be sharing that. And, if someone else can take that idea and run with it and actually do a better job than us, we hope they'll involve us. But really, our goal is to make things better.
Good morning, Tom.
I think someone needs to mute there.
Could you mute, please? We're hearing some background noise. Could everyone mute, please?
Great, thanks. And we do have monthly meetings where we share the projects that we're working on. We invite people to attend either personally or virtually and provide input. We also have people come and talk about things that would be of interest to us, or come and present their ideas and ask advice from us, which we're happy to provide. So next page. So in the past, we used to run about 10 or 15 projects at a time, but now we've focused on 3 major areas, although we are open to other ideas. These are the ones that are just occupying us at the moment. So first one is virtual reality as therapy. This came out of the idea, sort of the Japanese forest bathing concept, where being out in nature provides all kinds of health and physiologic benefits. And we wondered whether we could recreate those benefits for people who couldn't access the natural environment due to whatever barriers they faced through creating virtual environments. So that was the beginning of that. We worked with people with mild cognitive impairment, but that suite of projects has really grown, and now we're working with people in the ICU, people with burns to try to reduce pain and discomfort. We're working with a pediatric group for vision rehabilitation when they've had operations that have affected their vision. So there's a whole suite of other projects there. A second project is the Overdose Response Network, which is really trying to recreate a rescue network for substance users who are most at risk of dying from overdose. And these are people who are using alone, either because they're socially isolated or because of the social stigma. And that's a whole other project. Finally, the one that we're most interested in today is the Norc Innovation Center, or what we call the NIC, and that's what we're going to talk about. So next page, please. So what's a Norc? If you just click, we'll get, so stands for Naturally Occurring Retirement Community. Click again. And really it describes a place. So it's a place where just incidentally, next click, more than 30% of residents are age 65 and older. So first of all, there's a lot of issues with this slide here. First thing is that there's no set definition of a Norc. And we kind of made this one up just because we had to have some kind of definition and some way of identifying buildings that might be candidates for what we call Norc programs. So this 30% of residents age 65 and older, that's just our working definition. The whole idea of a retirement community is also problematic because many older adults aren't retired or they're semi-retired. They haven't retired from the world. They're still quite engaged. And it kind of creates this sense of, well, you know, these older adults are somewhere else. They're out of the mainstream of society, which actually isn't true. There's also many older adults who don't want to be thought of as living in a retirement community when they're living independently in their rental apartment or condo or co-op. But unfortunately, this term Norc has entered the literature, and I've tried to introduce naturally occurring resilient community, but it doesn't capture the sense of urgency around aging in place. So if anyone has a better idea, I'd love to hear it. But so far, my team has insisted on sticking with Norc because it seems most recognizable. Next page. So we know in Toronto, about 36% of older adults are now living in high-rise buildings. And as I've said, these could be rental apartments. These could be, you know, below market, market, or above market. They could be social housing. They could be condos. They could be co-ops. And we call this vertical aging. There are also Norcs that are horizontal, but they tend to have a lower concentration of older adults. And we decided to focus on the what we call vertical aging in place. Next. So this is a map, which some of you may have seen, of all the Norcs in Toronto. So this is publicly available data. You can get this from the City of Toronto. We identified almost 500 buildings in the city that have at least 30% older adults over the age of 65. You can see there's a lot of concentration down the central core, but there's also a lot of them out away from the central core. And it amounts to about 70,000 seniors altogether. We know in Ontario, there's almost 2,000 buildings that could be identified as Norcs, and that encompasses way more seniors than all the long-term care and retirement, the formal long-term care and retirement homes that exist in the province. Next slide. So what's the difference between a Norc and a Norc program? And this kind of causes confusion. So I'll try to explain this. So a Norc, as I said, it's just a geographic place. It's just a place where if you count up the number of older adults over the age of 65, using our definition, there's more than 30% of that group of people in the residence. A Norc program, or what I like to say is an activated Norc, is where there's been a formal move by the community of residents to self-organize or to be catalyzed to organize mutual support of communities. So what we're talking about is when we say there's over 500, there's almost 500 Norcs in Toronto alone and almost 2,000 in Ontario, those are just places where there happens to be that concentration of older adults. When we're talking about the NIC, or our Norc Innovation Center, we're working with Norc programs. Next slide. So can we think more expansively about aging in place? And can we use this concentration of older adults in Norcs to more efficiently provide services and to self-organize or catalyze the organization for community development and community support? So, you know, I've been on the Seniors Action website, which is very impressive. And you folks are very aware of the province's approach to this, which is basically build more long-term care homes. And we know from COVID and even pre-COVID that almost 90% of older adults do not want to end up in long-term care. So this is not a people-centered solution. It's not even an economically viable solution. We have all these buildings that already have seniors in them. Can we do something to reduce the risk of ending up in long-term care or obviating that risk altogether using the existing infrastructure? Next page. So as Trish has already mentioned, it's really about building a community network. And it depends how you define that community, but it's not just within the residents, it's in the wider community itself. Next page. So how can we unlock the potential of a Norc? And it really involves these multi-stakeholder partnerships. So our approach is to look at developing community resources or identifying them. And this can be nonprofits, it can be volunteer organizations, it can be businesses that are open to collaborating with older adults in their residences. It can be looking at space. And because most of these buildings that we look at were built in the 50s and 60s, they weren't purpose-built to support aging in place. There are some opportunities to repurpose some of that space. We've looked at some retrofits to make them more community-oriented and community promoting. But we've also looked sort of future-looking at how can we design new purpose-built residences that are not intended to be long-term care or retirement, but intended to be independent living that would be more promoting of community. Health and social programs, the other part of the partnership. And what we look at is health across the spectrum. So the broadest definition of health, which involves societal health, personal health, and mutual support. So support by residents for residents. And finally, supportive technology. You may be aware, I mean, there's over 100,000 health-related apps out there in the universe, or in our universe, very few of which have any real evaluation as to whether they help or not. And we're committed to identifying and evaluating technology that people actually want and would use and would actually be helpful. So next slide, please. So now I'm going to talk more about the Norc Innovation Center and what we're actually doing. So we talk about advancing a 21st century model of integrated health and social care. And we've already talked about this being a community-led solution that provides new options for aging in place with dignity and choice. So I'm going to talk a little later about what it means to be a 21st century model. But I want to mention the integrated health and social care. So when we think of people, older adults living independently, you can simplify things by kind of a Venn diagram of two circles. There's a big circle of people who are healthy and want to stay healthy. And then there's a smaller circle of people which overlaps who want to get healthy or actually not get worse. And they provide, and they require different kinds of services. And we want to be able to integrate, we want to be able to organize those services and apply them across that continuum. Norcs aren't a new idea. So, you know, as far as we can tell, the idea of I mean, you can go back as far as, you know, the very first organization of human beings on Earth, or even animal tribes, or back to bacteria, which form mutually supportive cultures. It's a naturally occurring way for organisms to support each other. In terms of the actual term Norc, it seems to have come out of New York City in the 70s, where people started to self-organize to mutually support. This idea has grown across the world. It seems to have taken less hold in Canada, although it seems to be evolving now. And again, there's no set definition. Some of these are older adult centered, some are multi-generational, but they all seem to have this attribute of mutual support within the residents, and then some are reaching out more into the community for community supportive resources. Next slide, please. So how do we approach this? So we talk about co-creation. So we're not serving residents. We're not providing care. Care is a very problematic term for me. It's very hierarchical. There's people who are providing care and people who are receiving care. So we're talking about mutual partnerships with residents to identify their needs, for them to self-identify, and to create solutions together. Many of these residences have people who already have extensive leadership experience, in their working life or in their current life. And we also have the ability to provide some additional training, some additional support for leadership. One of the things we can do is provide connection to communities and providers. So both the social and healthcare system are very complex, very hard to navigate. And we're able to reach out and identify people and services in the community and in the healthcare sector, and then make them available to the older adults in the Norcs. And we can provide ongoing coaching tools and resources for people who do it themselves. So for me, the best success of the NIC would be when someone comes to us and say, I've heard about the Norc concept, and we realize we're a Norc, and we've already started all these programs, and we've been to your website, and we're using some of your tools, and we just want you to know that, and maybe we'll come to you at some point for some advice. To me, that is success. It's not us necessarily going in and catalyzing a situation. Next page, please. So what are the key ingredients that we've identified? So people want self-determination, autonomy, and choice. They want to be healthy and have a sense of well-being. That comes through mutual and social support. We all know about the epidemic of loneliness. Although one of the things people have to appreciate is that being alone doesn't necessarily mean you're lonely. Some people naturally are not social. They're very satisfied being alone and making social contact minimally. And there's other people who are very gregarious, love social contact, thrive on it, and absolutely need it. And it's interesting when we're engaging residents to try to walk that fine line between someone who doesn't show up, and that might be their preference, or it might be that they're actually facing barriers, and then trying to identify those barriers and deal with them. We know people need help with everyday things. And, these are the little things that cumulatively can result in loss of independence. And it can be something as simple as a light bulb that goes out is beyond the reach of someone to change. It creates an area of poor lighting. They trip and fall and break their hip. And we know that, unfortunately, 30% of people who break their hip within the next year will have died. And of the survivors, 50% of those will require a higher level of care. It may be that if someone, maybe even the next door neighbor, had come in and said, "Oh, I can do that for you," that terrible trajectory might be avoided. People need information and navigation, again, because of the complexity of both the social and healthcare system. And people need a sense of purpose and belonging, and that comes through engagement with the community. Next slide. So what could aging in community look like? And these are just some examples. There's many more. All kinds of volunteer services between residents, these kinds of informal connections that come through social events or more formal ways of connecting people who need things with people who are happy to provide them, organizing group exercise and social activities, having a buddy system. People often informally do this already. I know my mother had a friend who, at 11 o'clock every morning, one of them would call the other just to make sure they were okay. We can provide certain types of health services on site. So using our Norc map during the pandemic, we were able to identify places in the city that were both had highly vulnerable populations, and we overlaid that with a map of where COVID was highly prevalent. And then we overlaid that with a map of where the vaccine clinics were. And we were able to show the science table that they had put the clinics in the wrong place. And using that information, they corrected that and started providing mobile clinics in areas of higher prevalence and higher vulnerability. And we even organized vaccines to take place within Norcs. And we've done that in some of the buildings for flu vaccine as well. And a lot of this has been motivated by the residents themselves. Next slide, please. So where are we at with the NIC? So we've been working at this since about 2015. Our activities have spanned research, looking at appropriate technology, looking at architecture, both retrofitting and purpose building, looking at strategies for community development, for older adults, for different types of communities. And one of the other important areas is looking at health policy and building policy. So looking into the regulatory environment that might actually be a barrier to or promoting of Norcs and Norc services. Next slide, please. So I've referred to reimagining Norcs for the 21st century, and these are the items that I think make the NIC a little bit unique and a little bit different than what's come before. So first of all, we have this Norc Ambassador program, and I'll talk a little bit more about that in a minute, but it's basically older adults who self-identify as people who want to become either more active or leaders within their own residence and help promote Norc programs. In terms of catalyzing with residents as partners, traditionally the Norc programs have come about because there's some charismatic leader or someone with a lot of leadership experience within a residence who identifies the opportunity to put together social programs or mutual supportive programs, and the residents just do it themselves. And one of the questions we've asked ourselves is, if that has not happened, and we identify a building with this concentration of older adults, can we go in and say, hey, you might not know about this concept of Norc. Does it look interesting to you? Here's some of the things we can work with you on. Are you interested? And I think it's still a bit of an open question. How successful would we be when this hasn't spontaneously arisen already? Can we catalyze this? The third program is the Connected Care Hub, and this also makes our program a bit unique. We're actually a partnership between OpenLab and the Connected Care Hub at the University Health Network. And Connected Care is a program within UHN that tries to provide more of a continuity of care between the hospital and the community. And so we formally have partnered with them so that we can access UHN formal medical resources. We have different models of this, and we're testing out different models of care. But we do have a nurse practitioner as part of our program, and we have several other clinicians in the health professions. And when a resident comes to us with a health issue, our first go-to is always their primary care provider, because we don't want to disrupt their usual circle of care. If for some reason they don't have a primary care provider, or that primary care provider needs some additional support in getting the services the person needs, our nurse practitioner can often solve the issues for the resident. But because we're connected into UHN, we also have direct access to UHN professionals to navigating through the health system, and we can provide expedited care. Next issue is the digital technology that enhances aging in place. And as I've already mentioned, we've done a fair bit of research on what is available out there, both in terms of non-invasive monitoring, in terms of health-related apps. These things are coming out all the time. The ecosystem is changing so quickly, but it's not clear how much is actually useful and how much people actually want. So we haven't moved very fast on this. We've done a lot of background work, but we haven't formally implemented anything because we believe that building the relationships and the mutually supportive structures within the communities is the primary mover here and the most important thing. And if there's enhancing technology, it has to fit with enhancing things, not replacing things. And finally, can we look at more efficient service delivery models? So several years ago, I knew there was home care in Ontario spent about $5 billion on their services. It's really hard to figure out exactly how much money is being spent now. I saw on the seniors social action website that you folks had delved into this. It might be more than $5 billion now, but it's very inefficient. So using our Norc map and using information from the social for home care, we were able to show that multiple services, multiple different service agencies are often providing care within one building, or sometimes different health service providers were providing services to the same person without any kind of collaboration between them. So this is incredibly inefficient. And we are advocating for a different model of home care that would utilize this fact that you've got groups of older adults living together. Why not provide care to that group in a more efficient manner? And we have a white paper coming out, I think within the next month or two, that's addressing that issue. Next slide, please. So I've mentioned the Norc ambassadors. I'm not going to talk a lot about that, but as I said, these are older adults living within these communities who have come forward and said, hey, I've been a leader, or I am a leader, or I've been organizing social events in my community. What else can I do? And we have a whole program that helps support them, helps connect them together so that they can form a community of practice and share ideas. This, to us, has been one of the keys to introducing programs into Norcs, because you have someone who actually lives in the building, knows the community, and it doesn't replace, for example, a condo board or a co-op board. It's an adjunct, it's a collaborator, but as you can imagine, people being people, it's not always smooth, and sometimes it's seen as very positive, and sometimes it's seen as threatening. So these are all, community development management issues that are real, and we have to try to understand and work with. Next slide, please. So where are we at with the Norc Innovation Center? So right now we're working with 23 buildings, comprising about 3,800 older adults. We have two models, one with buildings just with ambassadors, and other buildings with ambassadors and a site coordinator. So someone from the NIC who is there 2 to 3 days a week, collaborating directly with residents and the ambassadors. And one of the reasons we have these different models is we're not actually sure what the right model is. This is really kind of a beta program where we're saying we're not sure what makes sense for all these different groups. So we have, as I said, we've got condos, we've got rental apartments, we've got co-ops, we've got social housing, below market rents, above market rent buildings. We have multi-ethnic buildings, we have sort of homogeneous buildings, and probably the models might be different for these different buildings, and the intensity of the engagement and the length of engagement before they're self-supporting, all those things might be different. And this is partly what we're studying. And then we've extended partnerships into these communities with over 50 different health and social service agencies. And it's interesting because of the complexity out there. There's sometimes volunteer groups or nonprofits who are out there willing to provide services, but people just aren't aware of them. And we're able to directly connect with them, talk to them, introduce them to the Norc programs in their area, and get partnerships going. Next slide, please. So this is just a testimonial from one of our residents. I'm thrilled beyond my expectations at what we've achieved and how it's changed the building from a cold high-rise to a community. So that's, I mean, that really warms my heart and really talks about the success of our Norc programs. Of course, many buildings that we identify already have social programs going, but they haven't developed that full integration community, across the social and health spectrum that we're promoting. Next slide, please. So these are resources that we have online. There's our website, uhnOpenLab.ca. There's the Norc Innovation Center, all one word, norcinnovationcenter.ca. And then the Norc Ambassador site, all one word, norcambassadors.ca. So I will leave it at that and open this up for discussion. I'm sure there's a lot of questions and much more that I could add.
Thank you so much, Dr. Abrams. We already have some questions, so I'm just going to pose the first one to you.
Okay.
It's from Miriam Tikal, and I hope I pronounced that right, Miriam. And please add, if you like, your own comments. But she asked, can you explain how the nurse practitioner works? I assume that the NP is available only to Norc communities, affiliate to NIC. What about other Norcs that are in development or are not part of the OpenLab project?
Right. So you're right. The NP is only available to Norcs within our Norc Innovation Center and Norc project. We don't have unlimited funding, and this is really a developmental project. We hope that when we can show the economic validation of this model, that there will be government funding to support this model throughout any group that can be identified as a Norc. In New York, they have specific criteria, and if they meet those criteria, the city will pay for 50% of the services, and the residents pay for 50%. That's not particularly the model we're looking for. We're looking for being able to identify the economic value of this to the government, the cost savings, and get this fully funded. In terms of how they operate, residents can come to either an ambassador or a coordinator and say, you know, I have a health issue. They don't really have to explain it. The first go-to, as I said, is always their primary care provider. But if that's an issue, then they get connected directly to the nurse practitioner who talks to them by phone or Zoom or Teams, whatever they feel comfortable with. She might be able to resolve their issue, or if not, she can navigate them through the system to get the help they need.
Okay, that's great. Just a quick question before we go to the hands up. Are there any Norcs in St. Thomas Elgin community that you're aware of?
I'm not aware of any. I know we could identify the Norc buildings, the ones that would qualify as a Norc, but I'm not aware of any with Norc programs. And we have focused on Toronto just because this is our kind of experimental model development space. But we are in contact with other groups across Canada who are working in the same space. Like out in BC, there's Hey Neighbor, there's Happy Cities, and I'm sure there's others that we're not yet aware of.
Okay, that's great. Thank you. Okay, so 4 people have their hands up. We're going to take you in order. Joanne Matruda, Margaret Oldfield, Rick Metcalf, and Helen Cooper. So Joe, if you'd like to go first, unmute, please. Good.
Thank you for your presentation. Most informative and enlightening. I'm the first time participant in a group like this, and I reside in Waterloo, and I'm concerned about having a continuum of service that provides the most independence and in a reasonable fashion. And my question is as follows. In your investigations of Norcs across the province of Ontario, you mentioned it's difficult to have one comprehensive model. But I'm concerned about has anyone anywhere created some in their Norc a flow chart for risk management and safety assessment? Because you have the ambassadors, you have the network, you have those people who are not expert nurse practitioners, physicians, social worker, etc., supporting others, but how do they manage safety? Is there a flow chart of decision making, say in this context it is wise to do this thing, and you know, a pamphlet to pass the buck to somebody that's more experienced? That's my question. Safety is number one.
Yeah, so that's a good that's an interesting idea. I'm just going to comment here that, you know, I've seen in the chat popping up OASIS. Yeah, the OASIS program. We were involved with OASIS way back at the beginning with Christine McMillan, and they've kind of taken off with Queen's University developing a much more extensive program, but we're well aware of them, and we've been partners with them for quite a long time. Going back to evaluating risk. So short answer is no, we don't have any kind of formal flow chart. We're still identifying what people feel they need. We know that falls, you know, when we look at the, we've looked at the paramedic calls to different buildings, and falls is the number one thing that happens and is the number one thing that takes people to the emergency department. So we've introduced falls clinics, and we have a partnership with, oh, I'm just blocking out the name, one of my senior moments. One of the hospitals in Toronto that has falls pendants, and we have on our staff an occupational therapist. So we've been running these falls clinics, which both assess the falls risk and supplies the falls pendants, which are monitored. And we're actually doing a study to see if it actually reduces falls and calls to the paramedics. But we haven't done a comprehensive risk assessment unless people end up coming through the Connected Care Hub, and then they do get an extensive goal-directed assessment around, what are their goals, what are their expectations, and then looking at what are the risks to that. But most of the residents in these places are independently living. They don't think of themselves as necessarily at risk or ill, but might just need support with little things and enjoy more community interaction. Other questions?
Sorry, Margaret Oldfield, you're next, and thank you for that comprehensive answer, Dr. Abrams. So Margaret, your question? Please unmute. Unmute. There you go.
Find the right button. Got it. Thank you. I live in a housing co-op, and to help out staff who were getting a lot of questions and to forestall people going into long-term care among our members before they need to, I did a list of, like your eyes, I did a list of alternatives to long-term care for people, particularly people with cognitive impairments in downtown Toronto. And what I'm doing now with our manager, our building manager, is trying to set up care coordination in our co-op. And one way we might do that is through Norc. We already have lots of seniors who are getting home care, minimal as it is. And also we have, because we have accessible apartments, at least 10, we have lots of people getting attended care under different programs for non-seniors. So we have these two groups getting care from different programs, and we want to make care a lot more efficient. We also need to have somebody who coordinates it. And when I was developing this list, I found that there are seven seniors buildings owned by the City of Toronto, defined as Norcs, obviously, because they're seniors buildings, and they got funding from the Ministry of Health to have a coordinator on site who is an LPN, I think. So we're looking to, one thing we're looking at is doing something like that. Do you know how we would do that and how we would get help to organize that? Is that part of being a Norc?
That's a good question. We know that the Toronto Public Housing is doing their own initiative, and we're actually working with them on that to see how we can complement that. Short answer is, I don't know how you do that at this stage. What we would hope in the near future is being able to demonstrate that having a funded person through, whether it's funded through home care or through some other government service or through a new Norc agency, where if you qualify as a Norc, you get this kind of funding to support a person like that, because it's just so much more economical, efficient, and person-centered to be able to stay at home. One of my colleagues says, in reference to all this, you're better off at home. You've been doing that for a long time.
Thank you.
Okay.
Truer words. Rick Metcalf, you have your hand up.
Yeah, hi. Thank you so much for your presentation, and Trish, really appreciate all the emails I get from your office. I live in Owen Sound, in an ideal condo community with 24 units, and with a large common area upstairs with industrial sized kitchen, and we play cards and we watch movies and have dinners. And presently I'm facilitating a memory course through the Alzheimer's Society, 5-week course up in the common area. But what I need is access to a Norc ambassador who can guide me, because I know there's so much else that I can be doing, and I need someone that could guide me step by step, take baby steps, and how to go about doing more of this kind of stuff. Is there someone I can contact for that, just to access the different programs and stuff like that.
Yeah, so first of all, let me know when a room becomes available.
There's at least one. I live in a very aging community. Like the median age is about 85. I'm the young pup of 74.
Right.
So I find there's a different with the older age group. They don't seem to be in tune with what is available for them, because they're the age group thinking that they're naturally going to go into a long-term care unit. But I agree with you, 95% of us, we don't want to go there. So
yeah. So in terms of, resources, if you go to our Norc Ambassador website, so it's one
okay,
word, norcambassadors.ca. There's some do-it-yourself tools there. And there's also there should be a contact email in terms of, if you have questions or further advice. As I said, our Norc Innovation Center, it's a limited project with limited funding, kind of trying to explore this space and find out, how to do this, what it's going to cost, and make the case that this should be widely available.
if I go to the Norc Ambassadors, is there somebody I could actually talk to?
There should be an email, and then we're happy to talk to people.
Okay.
I can't remember. There's probably not a phone number. We don't actually have any landlines.
That's been my frustration with Norc.
Yeah. But if
with,
you
with Seniors for Social Action, I'll send an email and they'll respond to me within a few hours.
Yeah.
And with Norc, I find it really hard to connect with you.
why don't you give your email to Trish, and she can forward it to me, and I will look at that website. I can't remember offhand what the connector is, but I'll make sure that we can connect.
Yeah, because I'm not technologically that literate.
Yeah.
My wife is, but I'm not.
Rick, we're all in that boat. So if you email Seniors Action Ontario at gmail.com, then I'll make sure that Dr. Abrams gets your email.
Okay. Thank you so much, Trish. I appreciate it.
Okay, no problem.
Okay.
Helen Cooper with Oasis in Kingston.
Yeah, thanks, Trish. I've heard Oasis mentioned several times. I thought I could offer a few bits of information. First of all, I'm just recovering from some kind of flu bug, so my voice is kind of funny. And I am Christine McMillan's unworthy successor. But I chair the board of the original Oasis in Kingston. And I've worked very closely with the Queen's research team. The Queen's team has also, for their evaluative research on the Oasis, is in partnership with both Western and McMaster universities. These are all people in the schools of rehabilitation therapy. The professors are in the field of occupational or physical therapy. And for some immediate answers, there is a new Oasis site in St. Thomas, and it's being overseen by the faculty at Western. Carrie Hand is the principal investigator. Also, somebody's mentioned in the chat, the Toronto Oakwood Vaughan, that is an Oasis site. And that is funded through general revenue that Oasis has been able to raise. The Queen's research team has now established 18 sites in total across Canada. 4 are in Vancouver, 2 are in Halifax. The remainder are in places in Ontario. I've already talked to Kingston's got 4 sites. Belleville has 1. Ottawa has 2 or 3. I can't do the mental arithmetic. Thunder Bay has 2. then London and McMaster Hamilton. The Kingston, Hamilton, and McMaster sites are the original sites established for the research project and the evaluation. And I defer to Dr. Abrams' comments. The initial results are very promising. There are fewer falls, there's fewer use for need for home care, there's deferral to long-term care, or simply no requirement for long-term care. It's a no-brainer. We are doing everything we possibly can to influence government in seeing the value of this. The research we have through historic efforts, Christine McMillan in particular, who was an extremely effective lobbyist, got the Ministry of Health to annualize the original OASIS site. But all the other sites are based on term grants, either through the federal or the provincial government, or a private donor. So ultimately, these sites to survive will need ongoing funding. And that's what we're working on now. In fact, I just came away from a breakfast meeting on that very topic. My personal observation, what is absolutely essential to any OASIS site is a paid responsible coordinator. And I think other people have raised that issue. Once a program is established in a Norc, it's in no way going to be static. I look at our original OASIS. We still have some of it was founded in 2011 for permanent funding. Some of those people are still in the program, living in the building, but they're now, 13 years older? So we now have an OASIS where people have very successfully aged in place, but they're now in their late 80s and 90s. And their needs for programming are distinctly different from what they were when they were in their 70s or 60s even. And I think there needs to be a means to go with the flow here. So we can't ask volunteers to do that. Volunteers come and go, they run out of energy, they have to deal with personal issues. The ultimate success of OASIS is through a paid coordinator. And so I can't emphasize that strongly enough. And the people who take on this job are remarkable. And they're there not to tell people what to do. They're there to facilitate what the people in the program want. Now, I think I've talked long enough, and so that's it.
Yeah, thanks very much. OASIS is a great program, and they're doing amazing work. We're all trying different models to see what different types of communities need, and I agree 100%. It is something that's a living thing. It has to evolve with the needs of the community.
Okay,
But,
thank you. Thank you, Dr. Abrams. We have 4 more questions and then I'm prepared to cut it off. Is that all right with you?
Yeah, I can stay on as long as people are prepared to stay on. So
Okay, then Sue Lentz, you have the next question. Please unmute.
Oh, I didn't think I raised my hand. Can you hear me? But I was just throwing into the chat that I agree with Helen around the fact that as you establish Norcs and as they continue over time, we need the ongoing funding source, and we need mechanisms that allow for the expansion of the repertoire of services, or the mix of services, the types of services that that respond to people's needs over time. And so that thinking has to be done. But I did raise a question about the collaboration of the NIC with women's, the H Lab, the Women's H Lab out of Women's College Hospital. is the nature of the research primarily what you were talking about, Howie, in terms of measuring impact on the health outcomes of the participants in Norc settings?
Yeah, thanks for raising the wall, the Women's Aging Lab at Women's College. They're our partners on the research side, and I should have mentioned them in my talk. There's just so many components to this program. Yeah, so the evaluation is multidimensional. So there's what we call developmental evaluations. So they're looking at what we're doing and feeding back to us whether we're being successful or not. And it involves interviewing both residents and us, the NIC folks. They're looking at a cross-section of outcomes. So there's social outcomes in terms of, there are measures of community, social health, social network, and then there's, health in the more formal sense. There's also the economic evaluation, because ultimately we want to be able to show that this is, it's hard in healthcare to show cost savings, but you can often show that you're providing more service at a lower unit cost. So rather than building, new long-term care homes, providing care that meets residents' needs in buildings and infrastructure that already exists. So it's a multidimensional evaluation, and WAL is our close partner.
Great. So I have Anne Marie, Christina, Unitarian House Ottawa, Donna, and Danielle. Okay, so Anne Marie.
Yes, thank you. And thank you so very much for your talk, Howie. It's so very informative. Myself and my friend America, who's here with me, we're among these seniors who live in their own home in a closed geographic area. And I'm wondering if you know or have heard of any models that are in place or being looked at to provide sort of the Norc type of concept to individuals like myself and America and our friends who still live in their own homes. Thank you.
Yeah, so interesting. I think out in Sook, out in Vancouver Island, there's a more of a community that's not high rise like that. It takes a little more thought to work in a residential type community. We had a great presentation by an architect who's looking at residential intensification to support aging in place. Her concept is that people who still have their own homes, it's not rocket science, taking in borders to live, cooperatively, developing additional residences on the lot that already exists, using sort of modular housing, integrating with community agencies and community resources that already exists to create, recreational and social hubs for older adults. But right now, I think there's no reason why people who live in a neighborhood can't start to see if there's other people in the neighborhood that would be of interest. I mean, where I live, we're in, semi-detached homes, and there's a group of us that kind of support each other through small things, car sharing, and just little tasks that one or the other of us is better at. But we could imagine this starting to extend to the larger community.
Okay, so the next person is Christina from Chats. Christina, are you still there from Chats? Okay, doesn't look like it. We'll move on to the Unitarian House in Ottawa.
45 45 retirement units, but we are 68 independent living apartments. Doctor, do you know whether the new Bill 135, Convenient Care at Home Act, is going to be helpful to create the support necessary to start these Norcs? It was convenient care at home, and I asked the question, convenient for whom?
Yeah. Well, you know, unfortunately, with the previous Liberal government, they were prepared to provide $15 million to us for an initial Norc program. And then, of course, the government fell and the Conservative government came in and that was eliminated. I don't know really the specifics of that program and whether it's actually going to be convenient. I don't think that unless there's a significant reorganization of the way home care is delivered, that pouring more money into it will make any difference.
Okay.
We
Okay,
can live in dream.
sorry.
Okay. Thank you.
Okay, is Christina with us? Christina Bazance from Chats? Okay, Donna, you're next.
Hi, thank you for entertaining my question. I'm hoping it's appropriate here. I have some laws that are looking at it's resident in an apartment building and you sell your place that you're living in now and you put so much down to reduce the rent, but I understand it's all seniors. Is that is that part of Norc as well, or is it something run separately?
Yeah, I'm not quite sure what that is. It's not one of the buildings that we're engaged with. I mean, you'd have to look at, you know, what the percentage of older adults is and whether there's actually organized programs.
Yeah, it's
There are-
100%.
Yeah. So then it becomes, you know, is there organized programs that would represent some kind of community development, community engagement,
Okay.
self-determination? Because, you know, one of the primary principles is this is resident driven. And, you know, I'm sorry, I forgot the name of the person who raised Oasis, which is a great model. There may be some communities that don't need formal coordination, but through a well-connected network of ambassadors would have the resources. And with a place like, for example, the Norc Innovation Center as a resource could help manage the complexity. But that's what we're testing out. We're testing out whether does every building need its own coordinator? Can a coordinator manage 2 buildings, 3 buildings? What does that look like? So going back to your question, it depends if there's actually intentional programs engaged, whether it's, you know, a Norc, which just happens to be a place, or actually a place with Norc programs.
Okay, thank you.
Okay, Danielle?
Hi, Dr. Abrams. Thank you so much for this presentation. It's been really informative. I'm working with Age Friendly Peterborough, working on one of the Norc ambassador programs. But I'm actually fairly interested in something that we are kind of maybe working on. We've had some Toronto senior buildings reach out to us. They've established a Norc, or they've gotten kind of the residents together and they're working on that. And due to funding options, I guess they've reached out to us to see if there's a way that we can create a cooperative. That's kind of what we do, a cooperative in around their Norc. And then that would offer, you know, home support services and support services in that building. But they would share the cost in that, because my understanding with what's happening with a lot of people right now with the Norc is that there's still funding issues. that are going on with this. So I think they're trying to alleviate that concept a little bit and get this more informally done. I'm just wondering if you've heard of anything like that where the residents actually do that cost sharing, or if you have a model in particular where that's actually happening right now.
Yeah, so that was, the original model in New York, and is a model in places where residents can afford it.
Right.
And as I said, there's no set definition of NORCs or NORC programs. I think they vary quite a bit depending on the residents' capabilities and needs. We do not have a resident paid model. We're funded by foundations and donors. We don't have government or hospital funding. So we're trying out different models to see what seems to work in different settings. But there's no reason why a group who have the resources couldn't get together and form a cooperative or a nonprofit to supplement their own services.
Thank you. Yeah.
Okay, thank you, Dr. Abrams. I just had a couple of quick things. And it may be more a local problem more than anything else, but I wondered, I assume hospitals have postal code information on where their admissions to hospital, to emergency especially, are coming from. And it seems to me that if citizens could have access to that, we may be able to organize better locally to see whether we can build supports into those local areas. And so the second part of that is, how do we get hospitals, if you have any tips, to cooperate with local citizens and to promote these kinds of new models and share some of that data with us?
Yeah, that's, that's it's a crazy situation. So, don't get me started on legal and risk management. Short answer is that hospitals would consider that as personal health information and would not share it. In order, we have health profiles on all our buildings, but not by residents, by postal code. So, and we had to go through like months and months of security and legal and, twisting ourselves into pretzels and jumping through hoops to get access to that. There's a non-governmental organization called ISIS. I can't remember what it stands for anymore, that has all the, OHIP and health information data that's highly secure, and you have to go through this process to get access. So we can say, we have this building in this postal code. Can you tell us how many people with diabetes, how many people with heart failure? And if the numbers are too low, they won't release that information because you could potentially then identify an individual.
Right.
It would be very useful, no question, for citizens to be able to access that. The issue of confidentiality comes up, and when you ask a lawyer to manage risk, they're going to try to eliminate risk, and they can't trade off risks and benefits. They can only see risk.
Yeah.
So it becomes a huge, huge problem to access useful information.
Yes, and not even aggregate information that I'm assuming on, like,
Yeah.
which buildings have the most admissions to emergency, for example.
Yeah. So again,
Not even that.
yeah, as a academic and health affiliated group, going through 9 months of forms and
Unbelievable.
restrictions, and we can actually get that data, but it's not available to the public.
Community groups,
And
okay,
we have to sign confidentiality agreements saying we can't share it.
yes, oh dear. Okay,
Yeah.
You mentioned a white paper. I'm assuming, will you give us a copy or a link to it once it comes out?
Absolutely. Yeah.
Okay, that's great, because we'll share that with our members.
Great.
Okay, I think we've come to the end of our presentation, and I want to thank you, especially for recognizing and promoting the ways that care is actually a partnership, that older adults actually have strengths and that they can capitalize on, and that system navigation and connecting people to care providers, especially friendly ones, is so important. So thank